So earlier we were discussing the acute pancreatitis. So this the remaining portion. Identify CT, identification of liver, spleen, pancreas, aorta, vertebrae, and stomach. Identification of massive pseudocyst. So you can see here we have this is very simple. This is your liver, okay. This is spleen, beautiful spleen, and here you can see this is your pancreas, and here it's you can say this area is changed, like the shadow is changed, hypodense, and this is showing acute pancreatitis or inflammatory process. And here this shadow is pseudocyst collection. It can be pseudocyst, it can be necrosis, it can be phlegmon, anything, you never know, but there is some collection. This is stomach, and it's the left, you can see the left kidney, and this is your lumbar vertebrae. So again here this is your liver, and we have this the gallbladder, the stomach, and here we can see the lumbar vertebrae, the right kidney, the left left kidney will be here. This is most probably the spleen. Here the pancreas a little bit, and we have this pseudocyst. Or you won't say the pseudocyst. This you can say this collection can be pseudocyst, can be necrosis, or phlegmon, or an abscess. So this was the about the aorta hits here. This is your aorta, and the right side will be let me clear this a bit. So you can say here this is the most probably this is the aorta because it's small. The inferior vena cava will be on the right side, here and here. Here is the hyperdense abdominal aorta. So moving forward, definition of pseudocyst. So collection of a less rich fluid encysted within a wall of fibrous and accumulation tissue. It does not contain a true capsule. So it's basically the parenchyma, the compressed parenchyma. So fluid, amylase rich fluid which is collected in the parenchyma of the pancreas, surrounded by granulation tissue or the parenchymal pseudo layer that follows the attack of acute pancreatitis, chronic pancreatitis, or pancreatic trauma. It required 4 weeks or more from the onset of the attack. Where is the location of the pseudocyst? Mostly retrogastric in the lesser peritoneal sac near to the pancreas. So remember, if you are confused during CT reading, so remember this is your stomach, and behind stomach we have the lesser sac. So this will always be present. Most probably this will be present in the lesser sac. Always. This is your stomach, so it will be here. Okay. So symptoms presenting of pancreatic cirrhosis. So remember, pancreatic cirrhosis can cause dull pain because of the stretch, and it can cause the obstructive jaundice. It can cause the vomiting, the gastric outlet obstruction by pressing the stomach. It can also cause the dyspepsia, vomiting, gastric swelling, and mild fever. And sometimes it can also cause problem in respiration as well. Differences between true pancreatic cyst and pseudopancreatic cyst. So a pseudopancreatic cyst is not closed and does not have a lining epithelial cells. It has a false capsule separating it from the nearby tissue. Rather, it's lined by fibrous tissue. Whereas true pancreatic cyst has a true lining of epithelium, and it's in the parenchyma. Diagnosis of cirrhosis through ultrasound, CT with pancreatic protocol, as we shown, MRCP, cyst fluid analysis. Okay, so the cyst fluid analysis, this is very important. Always remember, pancreas has some cancers like serous or mucinous cysts. which can be malignant, especially the mucinosis. So you have to take the aspirate cyst fluid aspiration analysis. So check for the carcinoembryonic antigen and CA125, low in cirrhosis and elevated in tumors. Fluid viscosity low in cirrhosis and elevated in tumors. Amylase usually high in cirrhosis and low in tumors. And then afterwards plan the management or what surgical or anything you want to plan. So what are the complications of pancreatic cirrhosis? It can rupture into the bowel, GI bleeding, internal fistula. It can it can rupture into the peritoneum, causes peritonitis, infection because it's fluid full of enzymes, so it can cause severe peritonitis, infection, abscess, systemic sepsis, cholangitis, enlargement, abdominal compartment syndrome, CBD obstruction, obstructive jaundice, bowel obstruction, portal vein thrombosis, pain, hemorrhage into the cyst, hemoperitoneum, any blood vessel which is passing nearby, because pancreas is very vascular organ and there are nearby very big vessels, so it can encroach or it can disturb a vessel, it can bleed. So management of acute pancreatitis. So before going into the management of acute pancreatitis, let's discuss a bit the management of pseudopancreatic cyst. So pseudopancreatic cyst, normally it heals by conservatively. You can leave it, but if it's causing symptoms, then you have to do something about it. So if it's infected, drain it outside. You can drain it outside, and if it's non-infected, you can drain it inside. For example, so the cystogastrostomy, make a connection or communication with the gastrium, so it will heal. And another thing is that endoscopic aspiration is not advised because it will make fistula. It can lead to pancreatic fistula always. And the other thing is that symptomatic can be dealt surgically, and also if it's greater than 6 centimeter and greater than 6 to 12 weeks, so you can go for surgical intervention. Management of acute pancreatitis, so it's according to CRISP protocol A, B, C, D, E. History, physical examination, ABGs, bloods, ultrasound, admission in ETU, ICU, scoring, analgesia, preferably opioid. Morphine should be avoided as it contracts sphincter of Oddi. Avoid morphine. Aggressive fluid dehydration, supplemental oxygen, invasive monitoring of vitals, central venous pressure, urine output, blood gases, frequent monitoring of hematological and biochemical parameters, including liver and renal functions, clotting serum, calcium, blood glucose. So calcium is very important, LDH is very important. Antibiotic, nasogastric drainage only initially, especially nasojejunal. Antibiotics if cholangitis suspected or necrosis. Abscess or ERCP is planned. Prophylactic antibiotics can be considered. CT scan essential if organ failure and clinical deterioration on sign of sepsis develop ERCP within 72 hours for severe gallstone pancreatitis or signs of cholangitis. Supportive therapy for organ failure if it develops inotropes, ventilatory supports, hemofiltration. If nutrition support is required, consider enteral nasogastric feeding, TPN in case of severe acute pancreatitis, octreotide, somatostatin to decrease the pancreatic secretions. IV PPI to prevent stress ulcer and erosive bleeding. So a rule of corticosteroids in pancreatitis: only in acute stage, suppress the release of inflammatory cytokines in acute pancreatitis, reduce the length of hospital stay, reduce the need for surgical intervention, reduce the mortality rate. How will you manage the pain in acute pancreatitis? Pethidine, meperidine is the drug of choice. No morphine, no NSAIDs. Okay, no morphine, no NSAIDs. According to WHO analgesic letter, pain medication begins with non-opioids like acetaminophen, ibuprofen, or both, but avoid this. If non-opioids do not relieve pain, mild opioids, codeine, or given. If mild opioids do not relieve pain, strong opioid like PCA and epidural analgesia. PCA means patient control analgesia and epidural analgesia, management of pseudocyst. Supportive treatment up to 40% of acute pseudocyst will resolve within 1 week. Percutaneous drainage under CT guidance with cyst fluid analysis. Internal drainage, cystogastroscopy, cystogeneostomy with cyst wall biopsy to exclude malignant true cyst. If not resolves after 6 weeks, infected thick cyst wall or size greater than 6 centimeters, so you go for these internal drainage. Antibiotics to use in acute pancreatitis: carbapenem, imipenem, carbapenem, and quinolone. They have best pancreatic penetration. How does a paracetamol overdose cause liver damage? So acetaminophen is metabolized primarily by sulfation and glucuronidation in the liver, but only 5 to 10% metabolized by cytochrome P45 to a highly toxic metabolite and acetyl benzoquinone, benzoquinoamine, and acetyl benzoquinoamine. So detoxification by glutathione. So N-acetyl P-benzoquinoamine detoxification is done by glutathione conjugation, as you can see here. So what will we do with paracetamol overdose, glutathione depletion, and N-acetyl P-benzoquinone accumulation in the liver, centrilobular hepatic necrosis, which can be fatal. So basically what happened, in simple words, you can say that paracetamol detoxification is produced a byproduct which is an acetyl p-benzoquinoamine. So it is tackled by glutathione conjugation. So if it is overdose, glutathione will be less, and glutathione is an antioxidant, you should know. So it can cause centrilobular hepatic necrosis and it can be fatal. So an acetyl treatment can prevent or limit liver injury by restoring hepatic glutathione concentration. Therefore, N-acetyl cysteine is used as a treatment of acetaminophen overdose. So this is the antidote. Antidote of paracetamol toxicity is N-acetyl cysteine. And remember, what is the side effect of N-acetyl cysteine? So the side effect of N-acetyl cysteine is diarrhea. It can cause severe diarrhea. Okay, so this was the part 2 for acute pancreatitis. Part 2 of acute pancreatitis. Okay, before finishing this video, we can come to the pathogenesis or pathophysiology of acute pancreatitis. So we studied that pancreatic, what are the causes? So duct obstruction. So any gallstone here in the CBD, any stone in the CBD will cause back pressure, or here in the pancreatic duct. So it will cause back pressure and it will cause stasis of the enzymes. So it will damage the pancreatic parenchyma. And acinar cell damage, directly acinar cell damage by trauma, by virus, and by drugs. Okay, by alcohol. And so these are the contributing factors. So what they do, you can see here, these are the factors. So they interstitial edema, impaired blood flow, ischemia. So it will cause acinar cell damage. Alcohol, drugs, trauma, ischemia, viruses, these release of intracellular proenzymes and lysosomal hydrolases. It eats up the pancreatic parenchyma. Metabolic injury, experimental alcohol duct obstruction. Alcohol can cause duct obstruction, constriction of blood duct. So it will activate the proenzymes and the different hydrolases and lysosomal enzymes, which can cause damage. So interstitial inflammation and edema, proteolysis and fat necrosis, lipase phospholipids, hemorrhage. Elastasis. Elastasis can cause the vessel wall damage. Okay, so these are the features of acute pancreatitis pathophysiology, combinedly lead to and then they cause release various cytokines and then lead to DIC and complement fixation and multi-organ dysfunction. So the result will be death.